Well, welcome to this presentation on I added this little extra to the title, Back to the Future, because recentering the ICF model and pain and clinical reasoning in graduate physical therapy education. Because really, kind of what I've been thinking about a lot in the 6 years I've been teaching pain education in our graduate program at the University of New Mexico is kind of models to help our students in the uptake of kind of clinical reasoning and related to pain and to integrate that with other kind of knowledge that they're given throughout their curriculum. And we'll go into a little bit of the history of the ICF model, but it was something that I was taught when I went through school in 2004. And there was some excitement around that time and thereafter, and there were some articles published. But since then, it seems like things have gotten a couple different directions, and um, there hasn't been a lot of translation to kind of these complex or chronic pain. And so I'll talk more about this, but really that's kind of this back to the future kind of theme is sort of a return to that time period and thinking about how we apply pain and to the ICF model and why this is important with our physical therapy students. All right, so what is the ICF model, or the International Classification of Functioning of Disability and Health? It's kind of a mouthful. Essentially, it's a biopsychosocial model of health and disability. I'm assuming most people on this call are familiar with this. Most people in education probably are. It moved us away from sort of a biomedical orienting of health and functioning, and especially disability. Previous to this, there was a lot of association with disability being tightly linked to impairment, and this development of this kind of created more of a flexible model for thinking about disability and functioning. It was endorsed by the APTA in 2008, so a while ago. And as I mentioned, there was a number of articles. There was one article by Sean Rundell and PTJ applying the ICF model to pain at that time point. There's been a few more since then and a few more in some other domains, but I wouldn't say, and recently in 2025, there was a kind of review of ICF model and physical therapy education. And, one of the main themes that review came up with was endorsed and not implemented, and considerable heterogeneity across programs and how it's implemented. And we'll kind of get into a little bit more of that and kind of some next slides. Um, and that's kind of what I saw in our own program when I started 6 years ago. There wasn't a lot of implementation of it. And since then, we've sort of implemented it more, but it's been heterogeneous across our different disciplines, whether that's neuro, orthopedics, or other specialized settings. We've gotten better and more integrated. But um, anyways, and so, in kind of thinking about this, there's two terms that I kind of want to define from the outset. One is transdiagnostic and another is a meta framework, and thinking about the ICF model as both of these things. Transdiagnostic, or this term transdiagnostic, is really kind of a movement away from diagnosis of specific conditions. And I know diagnosis is in physical therapy is a hot, maybe a hot button issue, but a issue that's been pertinent for a number of years, and people having different kind of viewpoints on that. In psychology, there's a movement. If you're familiar with in the psychology field, they have the DSM, the Diagnostic of Statistic Manual. It's like kind of like their rubric for making diagnoses, and there's been a proliferation of psychological diagnoses, but there's been a movement to try to focus on key underlying processes that contribute to all those diagnoses, and to focus on those rather than specific diagnoses like depression, anxiety, and all the different subtypes of different things. And so thinking about the ICF model as really a transdiagnostic, and that it's not focused on diagnoses, but underlying physiological, psychological, and physical functioning processes that are important to physical therapy. And a meta framework is an idea, like a conceptual framework, as opposed, can be very, very specific to a scientific discipline. But a meta framework tries to kind of link and conceptualize numerous kind of sub frameworks into a larger framework, into a unified system. And I think the ICF model is that as well. So why is integration, and kind of the emerging theme and the impetus for this is when I started teaching pain, it wasn't integrated with other kind of disciplines, and it still isn't. And I would make the argument it's still not integrated within our field. But there's many theories and models, and there's scientific explanatory models. I've sort of broken these into two different kind of conceptual categories. One is scientific explanatory models. We have bottom-up models based on neurophysiology, neuroscience, psychological models that are more top-down, like the fear avoidance model, focusing on psychological constructs. And then there's also socio-cultural pain models out there. That's kind of this outside-in sort of approach. So how does things in our social cultural environment affect sort of pain processing? Then we have treatment frameworks, and there's a variety of these in physical therapy. There's psychologically informed PT practice, modality specific, and you go into subtypes of all of these things, and then you have classification systems on top of that, and body region and condition specific approaches. So it's a lot. There's a variety of ways we can approach this, and I think integration is necessary really to try to, especially for PT students, to try to synthesize this information in a useful way, and so we can minimize the sort of bad variability of practice that we're all trying to work towards standardization and competency towards. Additionally, here's another number of the reasons why I've thought about this a lot, thought about it a lot, and kind of front and center in terms of improving DPT clinical reasoning around pain is social determinants of health. There's a study from a couple of years back looking at kind of public health outcomes and socioeconomic factors, health behaviors, accounting for by and large the large proportion of health outcomes, with clinical care following third, and quite a bit far behind those two major ones, two other factors. And I think that's telling when we think about some of our models that really put in the center neurophysiology or these clinical care, clinical reasoning, very clinical specific models, because we're excluding these other factors that are much greater, have much bigger impacts. That can we modify all of them? That's another question. But I think that they do constrain therapy and constrain the way we apply kind of our clinical reasoning in a number of ways. And so they have to be incorporated in some fashion. And I don't feel like a lot of the treatment approaches at this, or the treatment frameworks, do that very well. But the ICF model allows for that. Assessment priorities. Determining an initial place to focus for a student is challenging. Selecting an appropriate pain model or framework, applying these models, and then most importantly, and the thing I've thought about the most, is how do we link assessment to intervention? How do we provide, if not an evidence-based reason for why an intervention is being selected, at least a theoretical reason why these two things are linked and why the student should kind of select something versus another thing. And so these are some of the challenges and why I really feel like integration is needed in this field. And I think historically, when we look at the history of the field of pain and physical therapy, you can divide into three waves. If you're familiar with psychotherapy, they've done this as well. So this is where I took this from. But first wave, we treated chronic and complex pain the same as acute pain. This was, 20, 30, 40 years ago. Then we had David Butler, Lorimer Moseley, and others kind of advocate for psychoeducation or pain neuroscience education, essentially. And these became first wave treatments. We applied these in addition to some of the standard treatments. And finally, this third wave, and I think this is where we're at, or if we're on the leading edge of kind of where this field is going, is thinking about how do we fully integrate psychological with biological clinical reasoning. There's some attempts at acceptance and commitment therapy for pain in the physical therapy context, and cognitive functional therapy represent two that I'm aware of and I kind of work with. There might be others out there as well. In addition, thinking about the student perspective, why is integration needed? Consistency and coherence. We need to reduce the cognitive load for our students by using a familiar framework. Currently, and this is a personal gripe of mine, and it's certainly an editorial, my own opinion, is like we have this proliferation of models in neuro, pain, movement, different aspects of the movement system. And I think from a student perspective, trying to learn how to apply select assessment and move to intervention, it becomes very confusing when you have different models that's essentially a reconfiguration of the same variables. So I think also increase the likelihood that students are going to adopt this innovation, adopt our teaching and integrate it into their practice. Again, that's reducing this sort of bad practice variability that we're all kind of concerned about. And then consistency with the biopsychosocial approach. And then finally, being treatment and technique agnostic. There's not a, as many of us are aware, there's not in many areas a lot of research demonstrating superiority versus techniques of different kind of subtypes of approaches. And I also think really using a language that is agnostic to a specific treatment and technique. So those are other kind of reasons that I think are important. So how do I use this in my teaching and PT education? Well, this is kind of the outline of my class conceptually. So step zero is I provide the overview of biological and psychological models to provide that basic foundational understanding. Step one, we work on kind of assessment and we link these to different ICF domains. And then basically step two, we work on treatment, but we try to provide, or at least I try to provide a conceptual linkage between the areas that you're assessing and the interventions you're selecting. It seems and so, and then a couple of things that I think are make the ICF model particularly attractive, based on how you kind of conceptually uh, group interventions and assessments in terms of the ICF model is one, it allows you to identify, is this a, say, low complexity patient? If there's only one or two domains that are impacted in the ICF model, without looking at going into more sub details of that particular patient case, you can kind of know that you're already dealing with a lower complexity kind of situation than if if you flag multiple domains, if it's and I didn't go through and define all the different domains. I can do that in a second. I'm trying to move through this in a relatively brief manner, but also under the assumption that many of us are familiar with this model. But if there's multiple domains that are selected, let's say body structure function, activity limitations, participation restrictions, personal factors, then we know that we're dealing with a higher complexity sort of case. And then I think when we think about these third wave interventions, these interventions like cognitive functional therapy or acceptance and commitment therapy, these ones that are on the, again, like I said, the leading edge of our profession in terms of what we're trying to do, the attractive trait of some of these interventions and what other people are doing is that they provide an integrated language and framework across these ICF domains. It's not like I think, and that's really key for me, is to get students out of the mindset of just being like a shotgun eclectic approach, like where they just start selecting random things that aren't conceptually linked to each other, but to be thoughtful and at least have a theoretical reason for the reasons why they're selecting their interventions. And so I hope so. Instead of that's the basic kind of rationale. With the remaining amount of time here, it looks like we have about 7 minutes left. I real briefly want to go through two cases just to demonstrate that. And this is kind of the goal of what I work to in my class. So here's like the ICF model structured a little bit differently in a table, but we have each one of these domains. So body structure function is that area of the ICF model that deals with kind of physiology and anatomy. Activity limitations are sort of task performances in a controlled setting, if you want to think about that. It's like sit to stand, go up and down stairs in the clinic. Things that you might test in the clinic, but are more functional in nature. Participation restrictions are things out in the patient's lived experience. So, okay, a person maybe have an activity limitation of going up and down stairs, but how does that impact them in their life? Are they not able to go up to their bedroom on the second floor because they can't go up and down stairs? Or do they only live on a single floor home? And so that, going up and down stairs may not, even though they can't do it, may not necessarily be restricting their participation in any of their kind of key areas of life. So this is work, recreation, lifestyle. Personal factors are more the psychological aspects. So this is many of the things when in the pain world, I attribute or I kind of put fear avoidance beliefs, kinesiophobia, catastrophizing, all those constructs kind of in these personal factors, as well as depression, anxiety, health literacy, other things. Environmental factors are more the social outside determinants, both attitudinal in nature, but also physical environment, work environment. And then health condition is the kind of diagnosis, the underlying, if there is a diagnosis, it's the medical viewpoint of the particular patient. And under each one of these domains, I kind of have assessment areas, and this is how I teach our students. I kind of break each of these domains into these assessment areas, and then after that, I provide interventional strategies that target those key assessment areas. So, kind of in our standard orthopedic curriculum in our program, these sort of assessment areas, joint mobility, strength, coordination, go along with strength training, stretching, exercise, range of motion interventions, because that's what their target is. Um, if you're doing more coordinated activities related to a specific task, then those interventions would go more at attacking activity or activity limitations. Motivational interviewing, values clarification, um, um, more lifestyle changes fall in this participation restriction domain. Pain neuroscience education, personal factors, and then if you're doing any kind of service connection, that's going to be environmental factors. Um, so that's just a real brief that's the heuristic. That's what I'm trying to teach. And in terms of a case, so I'll go through two cases here in the last 4 minutes. I'm going to keep this pretty brief. These are abbreviated cases. I've got a QR code up here if you want to download and get the full meal deal in terms of the entire case. But in this first case one, the primary concern is persistent upper thoracic, lower cervical ache, left greater than right, several months in duration and exacerbated by prolonged computer use, dull ache, no trauma, no neurological symptoms, no functional limitations or exercise, not limiting of function or exercise. Aggravating factors include sustained postures, contralateral side bending, and ipsilateral rotation. Postural correction reduces symptoms. Tenderness over T1 through T4, lower trapezius, left, greater, and right. In terms of, you can look at the rest of the objective findings. It's not that interesting. But the psychosocial, strong social support, regular exercise, no psychological distress. All right. So if we put this into the ICF model, this is kind of the ICF model. So if we put this in terms of what I want my students to do is to identify kind of these areas. So tenderness, movement, provoke pain, postural sensitivity, that's body structure function, concern level, that's high or red in this case, because that's the domain that's most likely impacted. There's yellow for activity limitation and environmental factors. These could be contributing, but they're not necessarily primary or as at a high level. They could be kind of second order treatments that we move to if kind of focusing on the body structure function is not effective. And then these other domains are green. We don't see kind of evidence in this case in terms of things that we need to address. So this, I tell our students, because I don't teach our standard orthopedic kind of approach here, but this would be a patient your standard orthopedic approach would fall into, and you can use those techniques. And I try to make that connection with students because I teach after that content in our particular curriculum. In terms of treatment, again, focusing on mobility drills, scapular retraction exercises, manual therapy. We could do some postural retraining, endurance exercises for the activity limitation. And then if we need to, we can move to the desk work setup, ergonomic evaluation, if necessary, as kind of a second order treatment. But green zones we're not going to necessarily address. All right, so that's a first case, but we can see the dramatic difference. And this is something that working in the pain field, you might be familiar with seeing patients like this. This is a patient with widespread pain, 18 months, non-traumatic in nature, deep aching, morning stiffness, describes brain fog, you're suspecting fibromyalgia, but there's not, or that sort of kind of cluster of symptoms, but he doesn't have a formal diagnosis. Full-time teacher, high stress, reduced work capacity, intermittent leave, withdrawn from physical and recreational activities, low mood, high stress, fear of movement, social withdrawal. We have some objective findings in terms of increased tenderness to light touch, painful but full range of motion, cautious but coordinated, decreased functional testing with 6-minute walk and sit to stands, no neurological deficits. We've got screening high for kinesiovia, catastrophizing, and widespread pain index, and symptom severity index as well. So if we look at this ICF model, again, this is what I'm trying to get my students to do, but we can see there's numerous domains that are screening red, and we've got a few areas that are yellow. And I think what the key thing, the reason why, and I want to drive this point home in my last few minutes here, the reason why I think this is so important is to give students the flexibility, the clinical reasoning flexibility, to not just begin with body structure, function, and activity. This is the domain that, when students come to me in the third year, they're competent in, they're biased to think that way. And I think to practice at our full potential as physical therapists, we need to have different angles to enter this treatment, maybe focus on participation. It may or may not make sense, but having discussions around like behavior change from the outset, moving immediately to psychologically informed care, but having flexibility to approach this patient from numerous different ways and to realize the influence of those social determinants of health, those environmental factors that may be constraining your ability to work in the same way as another patient. Let's say this patient has limited health insurance, they're on Medicaid or something like that. Medicaid's a entitlement service for people that have low income here in the United States. If you're in Canada, you may not be aware of that, but it's one of our patchwork of entitlement programs that we have here in the United States. But they may be constrained in number of visits. So what we want to do, um, in the sense of if we had unlimited visits or a more flexible program, we could do a lot more, but our clinical reasoning may drastically change based on the constraints that we know in the environment and the social and the physical environment. So that was a lot to get through in 22 minutes, but hopefully it kind of provides an overview of what I'm trying to do in terms of the teaching and how I'm trying to approach clinical reasoning in our program. And kind of the rationale behind that as well. And I'd love to hear your feedback because this is something I haven't seen addressed a lot in the literature. It's not something I've seen addressed a lot in the continuing education area, whether that's like education for people who teach pain education, but it's also something that I haven't seen, out there a ton. So I'd love to hear feedback on it or critiques of it. If you got a bone to pick with anything I had to say, I'm totally game for that too as well.